Thank you, Mr. Chairman. Good afternoon, ladies and gentlemen. I apologize in advance for the slight redundancies with the previous talks because we're revolving around the same organs, so there will be necessarily some repetitions. So, right ventricular infarction. It's amazing to realize that this was not recognized before 1930, which is not so long ago. And it is even more amazing that until 1974, the role of the right ventricle was considered negligible for the hemodynamics. And probably one of the reasons for that arises from the models that were used to study the effect of a right ventricular infarction. People studied dogs, and again, a slide that Didier showed just earlier. I have to confess that most of my physiological background I learned from him, so we went back to the same old studies. But if you ligate the right coronary artery of a dog, nothing happens. Why is that? Well, because right ventricular ejection results from two things. One is the thickening and the shortening of the right ventricular free wall, and the second is the shortening of the left ventricle itself. If you ligate the right coronary artery of a dog, you produce specifically an infarction of the right ventricular free wall, and you do not affect the left ventricle. And because the left ventricular contraction is preserved, right ventricular ejection still occurs and not much happens if it is an isolated right coronary occlusion. So, unlike what happens in patients, this is a poor guy who underwent a kinking of its right coronary artery after a Bentall procedure, and you see that the kinking of the right coronary artery not only produced right ventricular infarction, but also a massive inferior and septal infarction. Therefore, you don't have anymore the resource of counting on the left ventricle to help the right ventricle to pump by pulling on the free wall. So, in humans, unlike dogs, less than 5% of right ventricular infarction are isolated. More than 95% of right ventricular infarction are associated with inferior MI, and 10% of them are associated with anterior MI. In case of an inferior myocardial infarction, the probability of having a concomitant right ventricular infarction increases with the importance of hemodynamic compromise. Of course, right ventricular infarction results from right coronary artery occlusion, but the severity of the dysfunction is not always correlated with proximal right coronary artery occlusion because it depends on the existence of collateral vessels, and this is highly variable among subjects. Acutely, right ventricular infarction is associated with hemodynamic compromise, shock, and in-hospital mortality, but it is rarely associated with chronic right ventricular failure, which means that if you survive, there is a good chance for recovery for your right heart, which means that we should be very aggressive to give this patient all the chances to overcome the acute phase. The consequences of right ventricular infarction, well, you have systolic dysfunction and depression of the right ventricular free wall contraction, diastolic dysfunction, which results in increased stiffness of the right ventricle and increased feeding pressures. And as Paul mentioned, you have this vicious circle starting as in a vicious spiral, which with decreased pumping ability, which reduces cardiac output and creates upstream congestion. Also, right ventricular dilatation impairs the left ventricular diastolic filling and systolic function because of the interdependence of the two ventricles. So you have low stroke volume, low systemic pressure, which decrease end organ perfusion. You have an increase in right atrial pressure, which increases opposition to venous return, reduces venous return and therefore cardiac output. And you have splanchnic congestion. And on top of that, tricuspid regurgitation worsens everything. because it reduces cardiac output, it produces right ventricular volume overload, and further worsens the dilatation, and it also worsens the splanchnic congestion. And because of that, upstream organs will suffer, and mainly the kidney and the liver, with, as Didier mentioned, decrease in kidney function and liver function, because these organs are electively sensitive to venous congestion and the resulting ischemia. Now there are some compensatory mechanisms for acutely impaired right ventricular function. First, you will try to recruit your interventricular septum through predominant right-sided contraction and paradoxical septal motion. This may contribute to right ventricular systolic pressure generation unless your septum is already affected by ischemia, as in the example that I just showed. You will have an increased contribution to the right atrial contraction into the right ventricular filling to try to overcome the reduced distensibility, but this will only occur if the right atrium itself is not ischemic and if you still have a sinus rhythm. So the therapeutic management of an acute myocardial infarction and shock. First, of course, early revascularization should always be your first aim. Fluids. We've said a word about the fluids. It's written everywhere that ischemic right ventricle cannot eject if preload is inadequate. But of course, there is a real danger, as all the previous speaker emphasized. If you give blind, massive fluid loading, it will further aggravate splanchnic congestion and end organ dysfunction. So, how to do it? Well, my suggestion is to titrate the fluid, not to give huge amounts, but small amounts, and monitor the effect of your fluids. So the most straightforward parameter to monitor is stroke volume. If you give fluid and stroke volume increases, that means the heart is able to pump it. No danger. But if you give fluids and if stroke volume does not increase, there is a very big danger of generating congestion. Another goal for the therapeutic management is to improve coronary perfusion pressure, and the drug of choice, as mentioned earlier, is norepinephrine. Again, this old physiological experiment, if you combine slightly elevated right ventricular afterload with minor pulmonary artery restriction and a little bit of ischemia, you will have a drastic decrease in your, a drastic compromise in your hemodynamics. But if you restore the coronary perfusion here by injecting directly into the right coronary blood flow, you will restore systemic hemodynamics. So to improve coronary perfusion, you use norepinephrine to maintain the right ventricular coronary perfusion pressure. For a long time, intra-aortic balloon pump was also a class 1 treatment, but recently there was evidence published telling us that there is no benefit of preoperative intra-aortic balloon pump in patients undergoing revascularization after myocardial infarction. We will help the right ventricle if we try to reduce afterload, and I really much like the data of Paul showing the increase in stroke volume resulting from the adjunction of nitric oxide. This is a proper way to assess the effect of a therapeutic management. If systemic perfusion is improved, that means it works. And of course, we have to optimize cardiac rhythm and try to prevent or correct for arrhythmias. The ultimate weapon that we have in situation of acute shock in a patient with acute right ventricular ischemia is veno-arterial ECMO. This can be used as a bridge to recovery. Remember, sometimes the myocardium is just stunned, and if you give it some time and you unload it, it will recover, and the function will become better after a few days. But sometimes it will not recover, and you will be left with a patient, and you can either offer him urgent transplantation if there are no contraindication, or if the right ventricle recovers but not the left, maybe you can offer him a left ventricular assist device as a destination therapy or waiting for a transplantation at a later time. And in some patients, you will be unable to offer anything and you will be stuck. This is an example of a patient with acute decompensation of ischemic cardiomyopathy and shock, and she was placed under veno-arterial ECMO. You can see here the venous cannula in the right atrium, the left ventricular vein through the aorta to unload this congestive left ventricle, and you have to wait and hope for recovery. And if the recovery does not occur, you're in a very big problem, and you have to decide whether or not you will try to offer this patient the opportunity to have a left ventricular assist device and try to guess whether or not the right ventricle is recovered adequately enough in order to tolerate to be on its own. And it's very difficult, in fact, to assess the right ventricular function in patients under ECMO. And this is a big problem because right ventricular failure is a major cause of death when we switch from ECMO to left ventricular assist device. So some authors have suggested that we should use transient right ventricular assist device when switching from veno-arterial ECMO to left ventricular assist device. And finally, people are preparing a new Impella assist device, which is supposed to be specifically designed for the right side, and that can be inserted percutaneously. But up to now, it has not been released, and only a few centers have had the opportunity to use it. So I don't know very much about this new device. So to summarize the therapeutic goals in patients in shock with right ventricular failure, I think our aims should be to improve the oxygen delivery to the right ventricle by increasing FiO2, increase right ventricular perfusion pressure using norepinephrine and maybe intra-aortic balloon pump, and provide early revascularization. We should titrate the fluids very carefully using stroke volume monitoring. We should try to reduce right ventricular afterload and facilitate right ventricular ejection, and the most convenient weapon is inhaled nitric oxide, also a little bit expensive. We have to correct for bradyarrhythmias and beware of dobutamine because, as was said just earlier for isoprenaline, it's a double-edged sword. It may improve right ventricular performance by improving the motion of dyskinetic left ventricular segment, but the danger is tachycardia and arrhythmias. And in fact, in the end, if you fail to restore correct function using medications and all these treatments, request the help of mechanical assist devices and veno-arterial ECMO. Thank you for your attention.